Hello, everybody. Tyler again. We are back to doing the video talk-throughs of these presentations. Um, Shout out to Captain West, who is a big supporter of this. Hope you're happy they're back and you enjoy this presentation. Um, but this month, for November, we're going to be going over brief, resolved, unexplained events, or also known as breweries. So we're gonna just go through the slides here. He already went through a case study of a child who had an episode of apnea, um, was considered to be a low risk infant, and was discharged with no concerning findings. But we're going to go more into what qualifies as a low versus high risk, what qualifies as a brewery, and why it's so important we transport these kiddos. So, brief, resolved, unexplained event. What is it? These are episodes that are sudden and brief, like the name says, so lasting less than 1 minute, that resolve. They have to have one of the following symptoms occur. So it has to be cyanosis or pallor, or it's basically just change in skin condition, um, absent, decreased, or irregular breathing, a marked change in tone, which we'll have some examples of that on the next slide, or an altered level of responsiveness. So this call is probably going to come in as a unresponsive, not breathing, maybe a sick child, but because it's so brief, as long as the parent doesn't take them basically into your station, um, upon your arrival, the child is probably going to be presenting quite normal. So, in order for it to be considered a brief resolved unexplained event, it has to be less than 1 minute. They have to return to their baseline after the event, and the event has to be one of these four markers. So, keep that in mind. So, when we talk about hypo or hypertonia, um, the marked change in tone, hypo is going to be a limp or a floppy baby. So you can see their head is kind of going back. They're not really having any resistance. On the other side, where they have the hyper, this is considered a stiff baby. Often you're going to see the hands are going to be clenched. The neck is going to extend back. The child is basically just going to clench up. So this may seem maybe like a seizure activity. Um, it will go through all the parts of the questioning through the event, where if a child had a seizure, that's more or less likely to be a brief result unexplained event just because of the criteria they are looking for. But if the mom or dad describes the baby as being stiff and clenching their fists, which isn't normal for them, or they become very floppy, that's that marked change in tone that does qualify for a brew. For people who have been in EMS for a little bit, this might sound really familiar. And the reason is because this used to be called an ALTI or an apparent life-threatening event. Why don't they call it that anymore? So most children who experience a brief, resolved, unexplained event usually have a normal physical exam. About nearly 50% will have an underlying medical condition that requires comprehensive care, which is why it's so important we transport these children. But for the most part, these aren't life-threatening events. So Brew better encompasses the transient nature and really the lack of underlying explanation as to why these events do happen. Um, a parent life-threatening event to a parent might sound a lot more severe than a brief resolved unexplained event. Um, we're still going to treat this very seriously in the field when we do come across it, but this name is better encompassing for what we're seeing in the field, symptom-wise, and ultimately with their diagnosis in the hospital if they even find anything. In the case study, we talked about how the infant was determined to be a low risk, so they were just observed and discharged. If you want more information on this, there's an article that is linked in the speaker notes. A lot of the information from this presentation was sourced from this, so if you want to do a deep dive on your own, this is a good place to look. But this is determining whether the patient is at a high risk or low risk for the event being caused by an underlying issue. Um, when we're talking about the nearly 50% that have an underlying condition that require the comprehensive medical care. So the following criteria would be considered a low risk infant after having one of these events. They're going to be older than 60 days. They're born on time, so not premature. They do not require CPR, and a little kink in this is going to be by a medical professional. So if a parent performs CPR on scene for the 10 to 30 seconds that their child is unresponsive, if they like get those instructions on the phone or maybe they're a trained professional themselves, um, that may not count for them being high risk. So it needs to be by a medical professional. So basically, the crew arriving, or if the child was brought into the hospital, um, and the staff there perform CPR, then it would be considered high risk. So by a medical professional, um, it has to be the ones doing the CPR. Another for low risk is going to be the event lasted for less than a minute, which can be a little misleading because we only classify these as brief resolved unexplained events if they are under a minute. So that gets a little confusing. But the last piece of criteria for a lower risk is going to be this being the baby's only event. So if the patient has a history of these, they're going to be considered more high risk. There's something that's causing this to happen on a more consistent basis. Now, when we go to the flip side and we're looking at having a higher risk for underlying issues, these are going to be patients that are younger than 60 days. They have a history of prematurity, especially if they're under the 32 weeks gestation. If they're born before that, they're at a much higher risk of there being underlying pathophysiology or pathology causing these events. We kind of harped on this already, but CPR by a medical professional, um, and if they experience multiple of these events, they're going to be considered high risk. If they do not fit all the criteria of a low risk infant, then they are automatically considered high risk. So that's something to keep in mind. And again, this isn't going to be something that we really make a determination in the field. This is more for the hospital, but something for us to be aware of. Given that these patients are probably going to be presenting normal on our arrival, the best thing we can do for them at that time and for care downstream is getting a thorough history. It is incredibly important for these pediatric patients who experience a brief resolved unexplained event. Um, we're going to most likely be able to see the kid right after. We're going to get a chance to look in the kid's home, and we're going to see some stuff that the hospital will not get a chance to see. So being very detail oriented and very thorough in your history and aware of your surroundings could be very helpful in their care down the road. So history gathering, a lot of this, we're going to go through some things you want to look out for, some good questions to ask the parents, or things you want to take note of. So before the event occurred, where were they? Were they at daycare? Were they at home? If they're at home or daycare, like were they in a crib? Were they on a mat, playground, anything like that? So location of the event. Was the infant awake or asleep when this occurred? Was the infant sleeping and then suddenly stopped breathing, and that's why they called? Or were they awake and then they went unresponsive? So that's a really good determinant. The position of the infant also matters, whether they're prone, supine, or in another position. Just another thing to note. And activity is a big one, especially if it comes to feeding. They have anything in their mouth, like if they got their hands on a toy or something that was too small for them, possible choking hazard, or if there's vomit or spit up. Captain Lane made a really good point. For infants 3 months or younger, when they feed and they're on liquids only, sometimes when they're clearing the airway, they hold their breath and they'll grimace and they will make it seem like they are choking. Um, but really, they're very good at clearing their own airways. They just do kind of this funky thing. Not something I've experienced or seen, but Captain Lane did make a good point that a lot of first-time parents do see this, and it does freak them out because it kind of looks like they're choking. Now, if that's what's reported to us on arrival, um, I don't think that's a good indicator to not transport. That's kind of a big risk you're taking in that part, but that is something that may give you a little peace of mind. You may be able to give the family a peace of mind. Say, hey, we should still get evaluated, but um, something to think of during the event. Were they active? So were they still being playful and they just turned cyanotic, or were they quiet? Did they go unresponsive? Their responsiveness, whether they're awake, asleep, or if they're altered, like just staring off into space, that's a good thing to note. Some of these are going to seem very obvious, like were they breathing or not? Did they appear to have some difficulty breathing? Did you see any like intercostal retractions, nasal flaring during this event? Were they choking or gagging? Um, Limp, rigid, seizing, change in skin condition, or their lip mucous membrane color? Most of the time, this information is probably going to be what you get right off the bat. Hey, I called because my kid turned blue and it didn't look like he was really breathing, but now he's fine. Something like this. So this information is probably be more forthcoming. It's the gathering of the information before and after the event that's probably going to be a lot more. Um, we're going to have to actually do some digging. So after the event, determine how long it was. Um, Take it with a grain of salt. The parent is probably going to be very concerned. Obviously, this is a very startling thing for probably what is a healthy child is experiencing this very weird event. So try to get an estimate of how long the event was, but just know that time may move a lot faster, a lot slower when this is occurring. But just having a good estimate to give to the hospital. How did the event end? Were they kind of slow to come out of it, like they're maybe in a postictal state and pointing more towards a seizure? Uh, was it abrupt? Were they having trouble breathing and then they're just fine? Uh, so good things to note on how they came back to normal. When you talk about like that behavior, were they usually like noisy and they had the event and they're really quiet and then they came back to baseline and were normal? Were they really scared, startled during it, fussy or crying? All good things to note. Another really big thing is going to be any interventions. So, did they have to like pick up the child to wake them up? Were they like rubbing the back or the chest to see if they were awake? Did they perform compressions? Even though we know that may not make a difference whether the child is high risk or low risk, ultimately at the hospital. But noting that if the parents started performing CPR is going to be very important for us. So outside of this event, we're going to want to gather some information that's kind of just related. And I guess another way to put this is going to be like their past medical history. So has the child been sick recently? Are they just starting to meet other people now? It's cold flu season. They had a fever, uh, and experienced maybe like a febrile seizure. Is there a history of illness? Do they have some sort of genetic condition that predisposes them to things? Have they had a brief resolved unexplained event before? Is this not the first time that the family has experienced watching their child go through this? Do they have a family history of early death, SIDS, or presence of any cardiac arrhythmias or any developmental delays? So this is all good information to pass on to the hospital. You got to think that this patient probably going to Maine Med in Portland, right? Uh, Going to our pediatric center. And if they're actually having a true brief resolved unexplained event, they're going to be fine for the ride. And you're going to have a lot of time where you're going to be able to get a very thorough history. When it comes to the physical assessment of a child, obviously we're going to do a thorough head to toe. And we're going to want to look for anything that might point us in any direction. Are they feeling a little feverish? Do we see any marks, whether it's accidental or non-accidental trauma? But we're gonna do a complete head-to-head on this kid. We're just a good reminder of our pediatric assessment triangle. Looking at their appearance, are they alert? Are they tracking us when we enter the house? How are they acting? Are they crying? Are they calm? Work of breathing, we kind of already hit on this, looking at like, are they having retractions? Are they nasal flaring? Is there any cyanosis, which leads more to the circulation? Um, so making sure we do a complete head to toe, looking for any signs of abuse, any decap TLS, and going through that pediatric assessment triangle. Again, probably going to be normal. but we need to do a very thorough assessment. This is what the hospital is going to use to determine if it actually was a bruit, or is there a condition that they have, or was there a traumatic event that predisposed the child to this. So hospital evaluation, we've hit on it before. They're going to determine whether this infant is high or low risk based on that criteria we already went over. If they're a low risk infant, they're usually not going to do a bunch of tests. They're going to see some observation for a few hours, and then they're going to follow up with their pediatrician and just keep an eye on the kid to see if they have any further events. High risk, based on findings from the history or physical exam or what the parent reports, uh, that's where they're going to start doing some more testing to try to see if we have um, any conditions that are causing this event that occurred. So that's a lot of the assessment and history gathering for these events. Now we're going to go through some protocols that are related. Uh, the big ones are going to be PINK 1, which is the Brief Resolved Unexplained Event Protocol. And we're going to go over the pearls. Then we're going to go through PINK 8 and 9, which is just normal pediatric vital signs. We're just going to look at the newborn to 1 year, um, just so we know the differences. And we'll go over the GCS for, they have a modified one for children. I think that's something that's probably not looked at a whole lot. It's a good thing to review. And lastly, because it's a child and, it could be abuse that is causing this event, and it's not a true brewery, we'll go over the protocol for child abuse, look out for signs and symptoms of abuse, and review that number that we have to call to report. So Pink 1, brief resolved unexplained event, cannot make it any more clear, any more set in stone that we do not sign off infants that experience a brief resolved unexplained event. And it says right in the protocol that if a parent or guardian is refusing medical care or transport, that you need to contact online medical control to get assistance to convince this parent to go. This is something, like we said, almost half of these kids may have an underlying medical condition that is causing this. So you really don't want to take the risk to sign them off. Um, and then, God forbid, they have another event that lasts longer and we have some more serious ramifications. Something that we didn't really talk about in this history gathering is kind of looking at the surroundings that you're in. If the child isn't like brought out to the door and you're able to go into the home and take a peek, um, look out for, are medications easily available? Is there a bunch of mold in the house? How's the caregiver's condition? Are they healthy? Are they someone that's maybe dealing with medical problems and aren't able to get around as well? Maybe they're not able to watch their child all the time, or they have a lot of medications that are out. So really looking for anything that could could the child have gotten into something at home that is causing the symptoms that they were called for. And then any concerns for non-accidental trauma, kind of going down that line of, is there any abuse in the home? And that's why we're going to go over that gray 19 through 20 protocol. But really, this protocol, we hit a lot of this throughout the presentation, the definition of it, what we're looking for question-wise. During transport, we're just going to monitor vitals, keep the child warm. So if you need to put them in a blanket, put them in a blanket and get them up to the hospital. They need really to go to Maine Medical Center Portland. This is not someone you would take Biddeford, take them to Biddeford with. No pediatric vital signs. Luckily, pretty consistent, excuse me, throughout that first year of life. Pulse going to be 100 to 160. And then if you're getting more towards the 1 year, probably not as high. Respiratory rate between 30 and 60. Again, a little lower as you get closer to that year mark. And their systolic blood pressure at a minimum will be 70. But you can see that go into the 80s and 90s, and that probably isn't super abnormal. And then blood sugar between 45 and 120 for a newborn. For everybody else, normal blood sugar. All right. So now we're going to go through think we skipped over the modified GCS. Yeah. Apologies. So modified GCS for infant and children. Um, it's the same scoring for eye-opening, verbal, motor. So are they spontaneously open their eyes? Do you have to call their name? Do you have to elicit painful stimulus? That doesn't change. You really get more of the changes that modify for infant and children with verbal. It's kind of weird to say oriented for a five in this category, but are they having appropriate behavior? Are they babbling? Are they crying because it's stranger danger? Um, so this is a really good protocol to reference in these patients to kind of track their GCS to see if they have any changes. Um, are they initially a 15, but now they're being really irritable and inconsolable, and they're not opening their eyes, and it's only to speech now. So that's going to be a good way to track their mental status throughout transport. Again, with these events, we're not expecting that to really change, but it is something to take note of. So I'm not going to read through every marker on this, but this is pink 9 if you want to read through it in a little more depth. Grade 19 through 20. So we're going to go over our child abuse, possible indicators of abuse. Injured children under 2 years of age, especially if they have any fractures or hot water burns. These are things that should not be occurring to these children that young. Facial, mouth, or genital injuries, atypical, diffuse, or severe injuries, poor nutrition, poor care. Uh, they don't want the child to be alone with the clinician. They called like hours and hours after. They were really hesitant to call. Um, you get story from mom and dad. It's really vague. It's not consistent between the both. Story is changing, or things just aren't added up. Um, the best thing to remember here is if we're going to suspect abuse, we're not going to accuse. We're going to do a very thorough assessment, very thorough questioning, and contact the right people, do a very thorough report. The big thing when it comes to pediatrics is doing a thorough assessment in history, something we're just going to harp on. So this page really just talks about doing a detailed physical exam, assessing the environmental conditions, the interactions between the child and the family, looking if there's any unsanitary conditions, and talking about how we need to make sure that we have a very thorough idea of what's going on. Assistance from law enforcement and online medical control might be necessary, so trigger that when you have to. The big thing I want to point out here is the number for child emergency services, or sorry, the child abuse support line for emergency services. It's going to be 1-800-452-1999. Sometimes if that number doesn't work, you might have to call adult. An adult will send you over or take the report for you. Had that happen once or twice. So remember, if you don't have these numbers in your phone already, you should probably add them. They're right in the protocol. This is just another set of symptoms or physical findings that we could see on a child that we should suspect abuse. This specifies under 6 months of age, or if the child is non-ambulatory. So fracture of a bone, substantial bruising or multiple bruises, subdural hematoma, burns, poisoning, or injury resulting in substantial bleeding, soft tissue swelling, or impairment of an organ. So all things we want to look out for, especially in those kiddos that are under the age of 6 months. That's going to do it for the presentation. Hope you enjoyed. Please reach out if you have any questions. You have that 10-question quiz that is always oh so challenging. So best of luck. Just need a 70 to pass. Thank you for listening.